Come.
Sure.
Okay, so I welcome one and everyone on behalf of ISA Coimbatore. And first of all, happy World Anesthesia Day to all. Due to the pandemic, we couldn't have a family get together, but at least we can have a virtual academic feast at least. So I welcome the speaker, Dr. Raju Polachella, and our moderator, Dr. Rajini Sundar, head of the Department of Pediatric Anesthesia of GKNM. Madam, welcome, madam.
Thank you.
Yeah. So, and I welcome the State President, Dr. Sudarshan, and the State Secretary, Dr. Kribakaran, for the online CME. I have invited almost everyone of Tamil Nadu State Executive Committee. Let's see, maybe they will join a little later. So we can start the meeting. It's up live to you, madam, Rajini, madam.
Hello, good evening. Happy Anesthesia Day to one and all. I thank ISA office bearers for inviting me to moderate this session. I have great pleasure in introducing Dr. Raju, who is at present medical director in the pediatric chronic pain services. After doing his FRCA from UK, which was till 2014, he has moved to Canada, and I believe he has not done any adult procedures in the last few years. He's in education leadership program, and he is supervising and educating many budding anesthesiologists. It's a great pleasure to have you with us. So I request you to start your talk without any delay.
Thank you, Srinivasan. Thank you, ISA, for inviting me for this talk, and also thank you, Dr. Rajini Sundar, for accepting to be the moderator for this session. I also congratulate all of you on the eve of World Anesthesia Day, and you're doing a great human service. Especially during the pandemic, you have a lot of other responsibilities in the service of the public. The topic for today is anesthesia for pediatric ENT.
One announcement, Raju, excuse me, sorry, for 1 minute. If any doubts, you can post in the chat box. So at the end of the session, we will have the answers. Okay. Thank you, everyone. Sorry, Raju, you can continue. Yeah.
Another thing, I speak a little bit fast. If you don't understand, or if you want me to slow down, just tell me. I can do that too. The topic for today is a pediatric anesthesia in the ENT procedures. I made it to cater for different levels of training as well as levels of comfort. The reason being, some of them may be not available in India. Some of them may be available in India, but however, the basic principles of ENT anesthesia would remain the same. So what are the basic principles? Most of them are ambulatory or day case surgeries. And some of them, except the ear and other procedures, they are mostly shared airway procedure or shared space procedures, because it's head and surgery. You want to ensure that there is a smooth induction as well as smooth emergence for these type of patients. And sometimes the surgeons may expect some kind of a bloodless field, therefore expect you to provide hypotensive anesthesia, and therefore you may have to modify your technique. So you will probably want to avoid narcotics or the opiates or the or morphine or hydromorph or So you may want to use multimodal analgesia so that um, it is opiate sparing type of analgesia postoperatively. Emergencies may be challenging, or emergence during anesthesia may be challenging too. Often associated with the comorbidities, so you probably won't get the ASA1 or ASA2, but sometimes you may get ASA3 and ASA4 patients as well. One of the most common side effects, which significantly delays their discharge, is post-op nausea and vomiting. And you may have to come up with novel ideas on how to manage those. Um, you probably want to have a very good relationship with your surgeon, and therefore you can expect better outcomes. So what are the pre-op assessment you want to do? And most of the kids will come, especially during the winter time, with upper respiratory tract infection, or called RT. And therefore you want to time your surgery accordingly. And some of them will have a nasal obstruction, therefore they are mouth breathers, and it'll have a significant impact during inhalation induction. Um, and therefore you may have to cater for those needs. You also want to look for drugs which sometimes the patient may be on, which may increase the bleeding tendencies. And always look for comorbidities like syndromes, obesity, polysaccharidosis, and bleeding disorders. So they may modify your anesthetic technique. Look for laryngotrachea malacia, especially with pre-term kids, and look for other congenital abnormalities like webs, laryngeal webs, and laryngeal clefts. And also, if the patient has had a prolonged stay in the intensive care, look for subglottic stenosis. Um, the other important factor you may or may not want to know is the obstructive sleep apnea, which significantly has a effect on your anesthetic technique. And sometimes they may have a undiagnosed OSA, which may lead on to issues like polycythemia and corpulmonale. Um, Look for TM ankle, temporomandibular ankle joint ankylosis, so which may impede your anesthetic technique, also airway technique. Um, RT, which is sometimes we will scratch our head whether to postpone the surgery or go ahead with the surgery. And you may want to have a few significant features that before postponing your surgery, but you also will have a dilemma whether the child is actually fit enough to have the surgery or not. There are few or far incidences why you may want to postpone the surgery. If the child is unwell or lethargic, or if he has a temperature or a fever more than 37 degrees, has a purulent nasal discharge which is discolored, green or yellow sputum, um, or if you find abnormal auscultatory sounds like wheezing or crackles or crepitations. Those cases, my personal view is postpone the surgery at least 4 to 6 weeks. So this is the study done by, or the algorithm done by Shobha Malviya, which she's also one of my colleagues, works at Michigan. So if a child comes with an RT or upper respiratory tract infection, you want to determine whether surgery is urgent or not. If it is in yes, take the risk benefit ratio into consideration and proceed. If the surgery is not urgent, then you may want to find out if it is infectious etiology or not. If the symptoms are severe enough, and then you want to go back again whether surgery is urgent or not. If not, postpone for 4 to 6 weeks. If it is not infective etiology, if the mother or parent says, "Hey, this is the baseline of this patient," then you may want to proceed with taking the risk-benefit ratio. Um, if if the surgery is urgent, then you want to decide whether you want to give general anesthesia or not. If general anesthesia is not required, then you proceed. If it is required, then you may want to take all the other risk factors into consideration. So overall, if you want to postpone a surgery if you're suspicious of bad outcomes, at least 4 to 6 weeks for the infection to subside. Um, so you may want to consider other factors as well. How long the child has traveled to come to a center. Um, when our rule of thumb is if the child has traveled more than half an hour, then we will actually say the patient has to stay in the hospital. And you also may want to consider the childcare issues and also other socioeconomic issues as well. If the parents may be daily wage earners, and they may don't want to take time off for another day, then you may want to take that into consideration when you're actually postponing the surgery. Um, it is not easy for a patient who is actually having an upper respiratory tract surgery to be symptom free. You may want to time this patient in a symptom free window. For example, you may want to have an elective surgery during the summer months, during school holidays. Then you may want to time the surgery during that period of time. Um, Abnormal lab investigation also will actually influence your decision to postpone the surgery, and also the chest X-ray. Idea is if you want to postpone, at least postpone for 4 to 6 weeks in terms if there is an infection. Um, so what is OSA? So obstructive sleep apnea. It's an extreme form of sleep disorder breathing. High incidence, especially with Asian, African American children. This is very common here. I'm not very sure about India, but have a high index of suspicion, especially with adenotonsillar infection. Um, but if they are syndromic, if they have dysmorphic features, look up for this kind of syndromes like Cruzon, Ebert's, Treacher-Collins, Pierre-Robin syndrome. So they may pose a different challenges during conduct of anesthesia. Um, Look for this for especially with cerebral palsy patients with neurological attended patients for hypotonia, and they may present with obstructive sleep apnea. There's high incidence of sleep apnea in childhood obesity, which is becoming quite an epidemic nowadays, with lots of Western food available in India. So what is obstructive sleep apnea? You have to look at the triad of OSA or obstructive sleep apnea. It's airway obstruction, hypoxia, and hypercarbia. How would you know hypoxia and hypercarbia? By doing blood gas or serial blood gas or pulmonary. The extreme form of OSA will have polycythemia and also cardiac failure in the form of carpulmonale. How would you identify in babies? So if you get the history from the mother, they will say, "Hey, he or she, the baby is actually having a restless sleep during night, a lot of nighttime sweating, snoring, audible noisy breathing, and apneic episodes, unusual sleeping positions, frequent night awakenings. Sometimes you may hear about complaints of bedwetting, frequent bedwetting, and also daytime somnolence. You look for those symptoms as well, and also trouble falling asleep in the nighttime. So these are the indications that you may want to suspect obstructive sleep apnea. So when do you want, the other question is when you diagnose a patient has got sleep apnea, then when do you want them to be in hospital admitted or overnight stay? So these are the at least 8 consideration you want to take into account when you're actually making that decision. So anyone under age 3, with the cardiac complications, craniofacial abnormalities like dysmorphic features, obesity, and if you have a very abnormal polysomnogram, Failure to thrive is another important thing, neuromuscular disorders and persistent sleep disorder breathing. So these are the factors that may influence you to get this patient admitted overnight. Remember, I was saying this, we do this as a daytime ambulatory procedure, but there are factors that you may want to consider before you want to admit the patient overnight. Um, so one of the commonest surgeries that we do in ENT is the adenotonsillectomies or tonsillectomies that we was commonly known. Most common surgeries in the children mostly are day case surgeries or ambulatory surgeries. You do the surgery and they go home the same day. Um, Adenotonsillar hypertrophy is the most common form of upper airway obstructions in children. Um, Make sure that the patient doesn't have obstructive sleep apnea, and they may modify your anesthetic technique. Um, and especially if combination of obstructive sleep apnea and sickle cell disease may influence your anesthetic technique as well as your hospital stay. Look for any cardiopulmonary complications that may happen in post-op. Um, so adenotonsillectomy, how is it done? You can do pre-medication, but avoid narcotics or opiates as a pre-medication, or benzodiazepines for pre-medication. Um, some of the obstructive sleep apnea patients may need overnight stay. Sometimes they may need CPAP or may need a prescription of diuretics. Sickle cell disease, look for hemoglobin. I think in India it's still 9 or 10. And we converted into milligrams percentage, so 90 to 110. Look for the levels of hemoglobin as and make sure that they are a bit below 30%. So how is it done? Most of the kids may or may not have an IV. So it's a choice according to your center, either inhalation technique or IV induction. You remember I was telling you about the mouth breathers, especially the mouth breathers. You may want to have an oral airway with a CPAP. You probably want to use a Ray or south-facing endotracheal tube or flexible LMAs. Some of the centers have started doing tonsillectomies under flexible LMAs. You may want to keep them spontaneously breathing or intermittent positive pressure ventilation. Look for endotracheal displacement, especially when they're actually inserting the mouth gag or Boyle stays gag, um, uh, and also during extubation. You will probably want to extubate them deeper under anesthesia, but also it will depend upon the level of comfort you guys have or awake. And we describe a classical recovery position, which is on the right lateral position with the head down, slight head down tilt, so that the secretions of the oropharyngeal will gravitate out and therefore doesn't cause airway obstruction or laryngospasm. In terms of when the patient comes with obstructive sleep apnea, have them intubated as usual. My preference would be put them on not spontaneously breathing, but put them on either pressure support ventilation or IPPV and a lighter plane. Minimal opiates, the rule of thumb is I usually have half the dose of narcotics or the opiates for these type of patients, or short-acting opiates. Sometimes they may not need any opiates at all, especially the severe sleep apnea kids. Uh, Always aim for permissive hypercapnia. So what is permissive hypercapnia? It's the CO2 level at the arterial blood gas, which doesn't change the pH of the which is within normal range. May need a nasopharyngeal airway at the during emergence, and always look for this whether they are severe enough to be for overnight stay. For the beginners, I would prefer them to be admitted overnight in the hospital after the tonsillectomies. We had a comparative study of doing these tonsillectomies under LMA or endotracheal tube. Some of the centers have started using LMAs with the flexible LMAs, which is available nowadays. The advantage is quite manifold. It is a straightforward airway, it doesn't go into the subglottic area. You can ensure smooth emergence. You don't need paralysis for inserting an LMA, but an endotracheal tube, you need a paralysis, and therefore you need to reverse the paralysis at the end. You can actually the patients actually spit out the LMA, including the any airway secretions at the end of the procedure. They usually wake up and then spit it out themselves, and therefore there was a minimized airway trauma. But the disadvantage is usually the surgeons will complain about it. It actually encroaches their area of surgery. But if you have a very good rapport or a very good relationship with the surgeon, you should be able to get away with this. But you may want to try this before you want to make it as a practice. Um, so what is the analgesia you may want to use? You probably want to give pre-op acetaminophen, or what we call it as a paracetamol in India. So judicious use of intraoperative opiates or minimize the opiates. What we prefer here in Canada is the multimodal. So we give pre-op acetaminophen or the paracetamol, and the post-op we also give ibuprofen. Some of the centers may not, or the surgeons may not want you to use ibuprofen because of post-op post-tonsillectomy bleeding. And we also started using dexamethasone as an analgesic. The advantage of dexamethasone, it acts as in three prongs. One is it acts as an analgesia. It's a very good anti-inflammatory, also anti-emetic. The dosage we gave is about 0.5 milligrams per kg body weight, and given at the time of induction. There is a comparison randomized double-side blinded studies done across it. So this is the Tableau column. If you look at some of the studies, the dosage of up to 1 milligram per kg, when you were between 0.5 to 1 milligram per kg, you probably hit all the advantages of the using a dexamethasone. Like emesis is reduced, your pain is reduced, and therefore you reduce your amount of opiates required for this type of surgeries. And also you feel good after taking steroids, and you feel that you because of the anti-inflammatory effect as well as feeling good, you start eating and drinking immediately post-op. So try between 0.5 to 1 milligram per kg body weight to the maximum of 10. I gave up to 12 milligrams to the maximum dose. So other type of surgeries is the myringotomies. So the myringotomies are the grommets tubes or ventilating tubes in the ear, done in patients with recurrent otitis media. It's patients sometimes may need repeated visits for repositioning of the tubes, or also taking of the tubes. It's an ambulatory procedure, very, very short procedure, usually done in about 10 to 15 minutes. So you probably want to have the patient have inhalation induction. Some of the patients may or may not require IV insertion. What I do is I give them both paracetamol as well as ibuprofen pre-op, and then not have IV at all for these patients. But sometimes it may requires very short-acting opiates like fentanyl, 1 microgram per or 0.5 microgram per kg body weight. May need Tylenol and paracetamol and ibuprofen post-op as well. Some people say it's not going to be painful, but I don't believe that. And most of the kids who are having the surgery, it's a very, very painful surgery. The other procedures we do encounter is the mastoidectomy, myringoplasty, and cochlear implants. And they are some kind of unique surgery that may require the special type of anesthesia. Especially the surgeons sometimes are demanding that they the outcomes for their surgical techniques depends upon the the bloodless field. So providing a hypotensive anesthesia will actually give them a clear bloodless field, and therefore the duration of the surgery will be reduced, and their outcome, surgical outcome is much better. Um, so the basic principles of these surgeries are they are most of them are prolonged surgery, sometimes range up to 6 to 7 hours. They want to preserve the facial nerve because they are somewhere in the vicinity of the facial nerve. So you may want to for intubation you may want to use a short acting muscle relaxant, and therefore the facial nerve is available for them to monitor or have a facial nerve stimulus procedure in the middle of the surgery. Um, they probably want bloodless field, so therefore they may expect you to have hypotensive anesthesia. And emergence is also an important event that can happen. So emergence should be smooth, and therefore it doesn't displace the graft that they're actually using. So this is important principles of the ear surgeries. So how do you control bleeding? So the three techniques that we use is the physical, physiological, and pharmacological. Um, so physical, so you want to position the head up tilt, and you try to avoid any airway obstruction that is externally placed. So make sure that the patient head and neck are in line with the body, and the neck veins are not obstructed. There's no chest or abdominal wall compression. You may find sometimes all the nurses actually using the patient's abdomen or the chest as a table for their tools. So make sure that those things are not done during this type of surgery. They'll not cause a significant amount of chest compression, but these are small things that matters, especially with the small children. Physiological, so you make sure that the airways are not obstructed. So you may want to choose whether you want to use a control or spontaneous ventilation. When you want to have a hypotensive anesthesia, I prefer controlled ventilation, but it's up to your center what you prefer. Make sure the patient is normocapnic. And some centers, they say hypocapnia makes better, but normocapnia is more or less enough for these type of surgeries. Try and avoid hyperdynamic circulation. And what is hyperdynamic circulation? Is tachycardia, which is unexplained, as well as hypertension. So both of them will increase the bleeding at the site of surgery. Avoid raised intrajugular pressure by making sure that all the physical and physiological measures are taken. Avoid unnecessary raised intrathoracic pressure and also abdominal pressure. And I use a physiological PEEP about 3 to 4 millimeters of mercury, and aim for a controlled hypertension. My preference is less than 30% of mean arterial pressure. But the pressure that was taken during the pre-op area will not be an ideal situation, because most of the kids are actually anxious and your blood pressure is quite high. But when you're taking it when they are in a normal resting state away from the clinic, you may get a better outcome. What are the pharmacological strategies I use in providing hypotensive anesthesia? So try and avoid antiplatelets, like especially kids who have taken aspirin, mini aspirin, or they are on anticoagulants. So try and avoid them. Sometimes I use levodopa of dosage anywhere ranging between 0.2 milligrams per kg body weight to a maximum of 1 milligram per kg body weight. If you have esmolol available, use them. And there are other hypertensive techniques you might want to use, like a nitroprusside or other anti-hypertensive agents. My personal preference is remifentanil infusion, which gives you a very steady state. It is a very short-acting, ultra-short-acting analgesic, as well as gives a very steady state cardiovascular. I use in a dosage of 0.5 to 0.3 microgram per kg per minute. And it gives a very steady state and also very good hypertensive anesthesia. So other issues you want to take into consideration are use short-acting muscle relaxant, especially when when the surgeon says, I want to monitor facial nerve. Avoid nitrous oxide, which may or may not increase the post-op nausea, vomiting, and also it preserves the graft. And if at all, if you're using it, stop it at least half an hour before you're actually finishing the surgery. It can contribute to the high incidence of post-op nausea, vomiting, and dizziness. But you don't want the child to be vomiting and raising the intrathoracic pressure, and that may actually upset the surgeon because his surgery may not be a successful one. The reason being the graft may get dislodged. Most of them will need post-op nausea vomiting treatment, will need post-op analgesic in the terms of paracetamol and ibuprofen. The other important surgery, some of you may or may not be doing this, microlaryngobronchoscopies or the MLBs. It could be both for therapeutic reasons or diagnostic reasons. Usually can cause or may be used in mild to moderate airway obstruction. And the patient who presents with stridor, history of previous intubation, especially with the preterm or the patient who had spent a lot of time in the intensive care or in neonatal intensive care, and may sometimes may because of repeat intubation or during PDA ligation, you may have caused recurrent laryngeal nerve palsy and therefore causing airway obstruction. Sometimes you may want to do this procedure for a tumor decompression. So there are multiple ways of grades of airway obstruction. So grade 1 is no obstruction at all or mild obstruction up to 50%. And grade 4 is you cannot see the lumen. And that's just a severe form of obstruction. So in those cases, you may want to consider pre-op tracheostomy. So why did I put this slide? So it's a continuation of this slide, where you want to prepare yourself with an endotracheal tube, appropriate size endotracheal tube. For example, in a 6-year-old coming with 70% obstruction, you want to be ready with an endotracheal tube of size 3. What my preference would be, have size 2.5 and a 3.5 and a size 3 ready. So 3 sets of tubes ready. For example, if a 9-month-old coming, 9-month or 2-year-old coming with an 80% obstruction, you may want to have an endotracheal tube size of 2. So have those ready, especially with these type of patients. When they're during induction, they may completely lose the airway. Then you may want to have the ENT surgeon readily available to help you with the tracheostomy. So preparation is important and paramount in this type of scenarios, especially with kids who have more than 50% airway obstruction. So why this formula is important, Hagen-Poiseuille's law. So when you have the diameter of the trachea reduced to half a size, your resistance across the trachea, the airflow across the trachea, which causes the resistance, goes up by 16 times. So that's very important when you're actually looking at this type of surgeries. And also, it will also important when you're actually trying to select the size of the tube. This is the formula that comes to handy, and how we explain how the resistance increases during a partial airway obstruction. So the ENT surgeons will use a separate or special equipments for this type of surgery because they may be using a dynamic study where they may ask you to have the patient in a plane of anesthesia where the patient is actually breathing, but actually also under anesthesia and also tolerating all this equipment. It's the shared airway procedure, but you have to find somehow how to keep this patient asleep. So some, and also oxygenation. Um, this equipment will have a port which actually has where you can have a venturi attached to it, or your anesthetic circuit attached to the side port. We'll also have a port which actually can open up the airway, where you can actually use an insert an endotracheal tube and therefore maintain the anesthesia. My preferred technique is I use a combination of technique. It will be usually be intravenous anesthesia as well as inhalation technique as well. Um, about I did a study of what would be the occupational hazard with the inhalation technique using these type of doing these type of surgeries. Um, Most of the time, the anesthetist is not exposed to high amounts of inhalation agents, and but the surgeons are exposed to high amounts of inhalation agents. Therefore, if they are doing this for almost more than 10 years, the cumulative effect on their liver is quite high. So we started using intravenous techniques. Um, my preferred technique would be using propofol and remifentanil infusions. Um, so the goals of anesthesia in this type of surgery is adequate oxygenation. Therefore, you keep your saturation in the optimal level. They may want to control the cardiorespiratory reflexes, because you don't want the patient to be coughing and bucking under anesthesia as well as they doing the surgery. Um, you probably want the return of air reflexes immediately after the surgery. So your technique should also matter in that cases. And also, you also want to prevent airway, pulmonary aspiration or the gastric aspiration during these type of surgeries. Um, Monitor saturations and ECG and end-tidal CO2 in this patient. End-tidal CO2 monitoring is quite challenging because you may not get adequate CO2 available on the monitor. So in that case, then you may want to monitor the breathing physically with the visual technique. So most of the time, the surgeons do it as a dynamic study. Needs a high levels of expertise. It's actually a teamwork. I assign people during my conduct of this type of anesthesia their roles. So they one is in charge of the medications, one is in charge of the airways, one is in charge of overall management of this patient. Also make sure that the scrub nurses and the ENT surgeons are all ready to actually do the procedure. May need PCCU or intensive admissions post-op, but make sure that the bed is available. It is actually a teamwork, and it is actually when you have this well-oiled, you have the team dynamics adequately controlled. The whole procedure will work out like a well-oiled machine. So how do you want to perform this anesthesia? So you probably want to give anticholinergic pre-op by giving 50 microgram per kg orally. Usually I use sevoflurane induction. You can also use halothane or induction. I prefer not to use isoflurane. Most of them are spontaneously breathing. I prefer not to use muscle relaxant. It also depends upon the center. You can use succinylcholine. Spraying cords of lidocaine is also an important technique. Two things might happen when they are spraying cords. One is the physical properties of the lidocaine or the lignocaine will cause laryngospasm at the time. And as soon as the pharmacological properties of the lignocaine takes over, the cords actually gets relaxed. They want to use or choose a smaller endotracheal tube, especially with kids who have been having subglottic stenosis. Either want to prefer, depending upon the surgeon, oral or in nasal intubation. I use laryngeal mask airway for these type of surgeries. The technique I use is my propofol and remifentanil infusion. But Also, make sure that they do get the dexamethasone steroids, at least 0.25 milligram per kg body weight IV during induction. So there are different ways of timing the dose for post-op nausea for dexamethasone. My center uses at least zero point 0.5 to 0.1 milligram per kg body weight. Remember, we want to target the 3 advantages of dexamethasone. We give it during induction, and also on densatone at the end of the surgery. So there are 2 case scenarios I actually wanted to, you may want to discuss. The 2 scenarios are scenario 1 is you've been asked to call to see a 5-year-old child who had a tonsillectomy 6 hours previously. The child is bleeding and needs to go back to the OR or theater for homeostasis. When you arrive in the ward, the child is agitated and says he feels sick. Postoperative blood loss is reported to be minimal by the nursing staff. So on examination, he's pale. His pulse is 125 per minute, respiratory rate of 25 per minute. Blood pressure is slightly low for that age group, and capillary refill time is 4 seconds, more than 4 seconds. The questions you may want to ask is, what are the specific problems for this case? And we can discuss this as in the discussion forum. And how do you want to assess the hypovolemia in children? And what is the immediate management in the ward? We can discuss this later in the chat box. What are the things that you want to have in the discussion is heart rate, whether the heart rate is actually due to anxiousness of the patient or the hemodynamic instability that patient is encountering, especially with the hypovolemia. Bradycardia in this type of children, in this type of scenarios, is a late sign, and it's also most of the time it's a pre-terminal sign. So make sure when the child is in the bradycardic state with the hypovolemia, it is a pre-terminal sign. Capillary refill time gives an idea of how the hypovolemia state is. Blood pressure is difficult, especially with an agitated child. It's difficult to measure. Tachypnea or a respiratory rate increased is an important sign in children, especially. Remember, the cardiac the oxygen delivery is times cardiac output times the cardiac content, and tachypnea actually plays a role in that equation. Core skin temperature gives you an idea of hypovolemic status. And also, you want to look for urine output status. If the patient has not peed for the last several hours, there's decreased cardiac output to the vital organs. Blood gas analysis and metabolic acidosis is also an indication, will also give you an idea of how they are poor tissue perfusion or hypovolemic status. The scenario 2 is quite common. It's actually challenging. So a mother brings a 14-month-old child to the urgent care clinic with complaints of choking and gagging after eating potato chips. At the grandmother's house, the mother is unsure if he had eaten anything else with the potato chips and does not think the child turned blue during choking and gagging episode. He turned to his normal activity shortly after the episode occurred, but since then he has had a few intermittent cough spells. Patient has 2 older siblings who are still at grandmother's house. On examination, temperature is 37 degrees, pulse rate is 103, respiratory is 28, blood pressure is normal for this age group. Oxygen saturation about 96% of room air. He's walking around, he's running around in the exam room. It's with no acute distress. On physical examination, you probably have a low-pitched monophonic expiratory wheeze in a particular area on the side of the sternal notch. So there is clearly an indication that this kid has probably aspirated a foreign body, probably a chips or something. So what are the type of foreign body you probably encounter is the vegetable matter, about 60-70% of incidents. Most of them are peanuts or nuts. Sometimes the food itself. Sometimes you may find metallic objects like safety pins, or nowadays you have these batteries inhaled by small children. Sometimes the small plastic toys like plastic objects. So when these type of scenarios occur, it's actually challenging. Um, so what are the types of foreign body obstruction when these type of things happen? They may act like a check wall. So air can be inhaled, but does not exhale. So they may form an emphysematous areas. If you do a chest X-ray, you may have a localized emphysematous areas. Sometimes they act as a ball valve mechanism. Air can be exhaled but not inhaled. So it's a complete bronchopulmonary collapse. So you may want to get on with the removal of the foreign body straight away. Sometimes it may act as a bypass valve. Usually these type of patient may present late, and they pose different type of scenarios as well as challenges. The most life-threatening condition is the stop valve, the complete total obstruction, airway collapse, and consolidation. You may not have enough time to actually deal with this. So as soon as you hear them, you probably want the ENT surgeon there to do a tracheostomy in this type of foreign body obstruction. So this is my short presentation. I'm sorry I cannot give you a detailed one, but if you have any questions, we can start doing the discussion now. Srinivasan will have my email. If you want to post more questions, you can email me too.
Sure, sir. Sure. Madam, Rajini, madam.
Yeah, I saw in the chat box. That's a question regarding how do you use dexmedetomidine in your practice?
Yeah, we started using dexmedetomidine. The issue with dexmedetomidine is it gives a very good steady state anesthesia. It's also an analgesic, but the airway reflexes are not protected. So the reason why I prefer remifentanil, your air reflexes are actually obtended with remifentanil, but not with dexmedetomidine. The other disadvantage of dexmedetomidine is the cost. It's quite expensive using dexmedetomidine.
Most of the time, you topicalize the airway nicely so that the airway reflexes are obtended. Then what would you do for your anesthetics? You still don't want to use Dex?
Yeah, the problem with lidocaine or the lignocaine airway topical is most of the time you will not achieve the intended obtendation of airway reflexes. Then you have the choice of what you do, whether you want to use a dexmedetomidine or remifentanil. Again, dexmedetomidine is expensive and it's also not available in all the centers, but I'm not sure it's available in your center. Remifentanil looks like much more cheaper, as well as it's ultra-acting agent.
In fact, remifentanil is not available here. It's I don't know.
Sorry.
Yeah.
Sorry. You have dexmedetomidine, is it?
Dexmedetomidine is available everywhere.
Oh wow. Okay. That's so yeah. I take your point. So if dexmedetomidine is available, then please use dexmedetomidine with good topical anesthesia.
Some of the procedures may need intermittent intubation and extubation, isn't it? When you are working on the airway, that's going to be challenging.
Yes, especially with the broncholaryngoscopy. That's why you have the ENT surgeon as a standby. Also, you have a role assigned to one of the team member that person is in charge of the endotracheal tube to intubate and extubate. So that's where the teamwork comes into play.
Dr. Sudarshan wants to know whether you would prefer extubating the children on the sides all the time.
So I'm in the teaching hospital. So I teach the juniors. So that when you're teaching juniors, you want to create a kind of a safety mechanism for the children. The things which when I've been doing this for 20 years, I prefer not to any position is even enough for me because I know when to exhibit. But when you're actually teaching in a teaching hospital, when you want to teach the trainees, you want to teach the most safest way of conducting anesthesia, that including airway extubation. So the best extubation position would be right lateral tonsillectomy position for these kids. And if they want to extubate awake, that's also fine. So that's the reason why I prefer extubating them on their side.
Yeah, you have to practice what you preach. True. And another question is how often you see extubation stridor in the kids and incidence of sore throat and the treatment of choice.
So almost every patient who come for tonsillectomies will have sore throat due to the surgery itself. Whether intubation technique matters and the sore throat, the incidence I actually don't know the actual incidence, but the using of high dose dexamethasone has reduced the amount or the edema causing sore throat. What are the airway obstruction or the stridors that can happen after surgery? Again, it depends upon the level of expertise. If a person in the first few years of their practice, their airway obstruction is quite high, to a person who actually have a high level of expertise or doing this for years and years. So therefore, you find the trainees or the residents are doing on their own, their airway obstruction is quite high to a person who's actually doing it for 20, 30 years.
Do you have transcutaneous PCO2, PO2 monitor in your setup?
No, we don't have in the OR. It's available in the intensive care.
And how about your experience with Heliox?
Heliox, we don't use Heliox here. We don't have it in our setup. Yeah, that's another technique that some of the American centers use because it has a low density. Therefore, they are very useful in airway obstruction or partial airway obstruction. That's a good question.
Okay, so I have a question. You mentioned about the bleeding this thing for drugs. So what does pediatric group have drugs that tend to bleed?
Yeah, some of the kids who actually have polycythemia, especially the obstructive sleep apnea, they may be on aspirin, mini aspirin. Sometimes some of the kids have previous embolic or episodes. They may be on aspirin, so make sure that they are gonna. Sometimes warfarin is prescribed in cardiac kids. Sometimes they may be on a deltaparin or low molecular weight heparins. So make sure they're not on those type of medication. You may not see them every time, but these actually matters when these type of surgeries.
Do you use tranexamine routinely for your tonsil kids?
In our center, no, because the nowadays that they use the cold diathermy, which is actually significantly reduce the bleeding in this type of surgeries. So no, madam. We have actually used tranexamic acid in cleft lip and palate surgeries to reduce the blood loss.
There is a question from the audience. Dr. Dinesh, he wants to know whether you use blocks for tonsillectomies.
We tried this. Yes, I take this point. We tried this local blocks for tonsillectomies, but we discontinued that practice because we didn't find enough evidence to say that this patient um, benefited from a block, and especially when you don't know where it's kind of a blind technique. You're actually injecting somewhere closer in the vicinity of internal carotid or major vessels. So you probably if you actually inject into the internal carotid, then you are in a really deep trouble. The other thing is we don't know what the absorption rate that the local anesthetic may go into this, especially the vascular spaces within that area. So we tried a few technique, and we also tried the topical lidocaine on the tonsillar fossa. And when compared that to the safe technique like a multiport analgesia, we didn't find significant amount of difference in pain reduction.
So what about the local spray after tonsillectomy?
That's what the problem with that is we don't know the absorption rates. We also don't know whether they provided a significant amount of decrease in pain reduction, but it may add to the multimodal analgesia. But there's no doubt about it. Some of the kids may not like the feeling of the throat being numb after the surgery.
Okay.
It's kind of a different feeling for them.
Yeah.
And definitely the cough reflex gets diminished when you're spraying.
Yes,
That's what
absolutely.
I have noticed. Yeah.
Yeah, absolutely, ma'am.
So in fact, I'm very happy to have this lecture today because I do almost 3 to 4 pediatric ENT cases a week. Almost monthly, once or twice a cochlear implant. So how much do you bring to the hypotension of this cochlear implant? Because they mastoid and cochlear implant, they usually the surgeon refer to my surgeon. He personally asks somewhere. He'll be very happy if it is the BP is 60/30. But he's really happy. But I don't know, that cannot be allowed. But how much do you prefer?
So, for example, I mean, I go up to about 20 to 30% of mean arterial pressure. So, the way I do it is that I'm actually, I take the first blood pressure before the surgery, and then determine what the mean arterial pressure at that point of time, and then bring it down to about 30% less to the first blood pressure. Most of the time you actually hit the target. Anything less than that, I actually don't know how to actually say what will be the outcome. But surgeon may be happy, but you may not get a very good outcome in terms of post-op recovery.
We have one more question from Dinesh Kumar. Opioid-free anesthesia for tonsil.
Yep, it's a good question, Dinesh. So opioid-free anesthesia, you can do that. Some of my colleagues use ketamine as an analgesic, and high-dose steroids and multimodal anesthesia. It's very good technique, especially when you want to avoid opiates. This is a very good technique, especially the kids who have obstructive sleep apnea, or you are working in a center where you don't have narcotics available. Ketamine is also as an alternative, promotes opiate-free anesthesia.
So I think everyone can talk if anything. If any of you have a question, I think I've allowed everyone to unmute yourself. any questions you can ask, because we have I don't know. I expect number around 150 today. That's what I promised the speaker also. But somehow today the speaker, the participants are less.
Puja first day. Navaratri first day.
Yeah.
Subhaya, anything?
Yeah, hello. That was a nice talk, Dr. Raju. You mentioned in your talk about use of nasopharyngeal airways in pediatric.
Hello.
You have nasopharyngeal pediatric airways, yeah?
Yeah, we do have.
What size do you have?
So if your center doesn't have nasopharyngeal airway, you can convert an endotracheal tube as a nasopharyngeal airway. So all you have to do is cut the endotracheal tube to the length of the tube you want, and then use the connector at the end of the tube.
No, but actually we have a
Pediatric.
thing. Ramson has it, I think. Am I right, madam?
Yes.
Yeah, we are having all sizes.
I do have all these items.
We have some
Yeah.
nasopharyngeal pediatric airways. They are very cute little things, no? Different colors and all. We have so many companies supplying.
Because I get Ramsons because it is cheaper. Maybe you are in a setup, corporate setup. You can go for
There, quite a few are there.
Yeah.
Actually, we had problems procuring nasal airways for children. But I suppose Romson will be able to supply it. But on the odd occasion when we need to use it, we have actually did what you actually mentioned, cut the endotracheal tube. But one of the problems we need to be very wary of is these tubes are actually rigid.
Yeah.
In children, you can easily cause trauma, and quite often you do a adenoidectomy. You actually push the endotracheal tube, a regular endotracheal tube, through the nose of a small child, especially if it is not very soft. The other problem with Romson is not long enough, even for adults. If you actually put a size 8 Romson in adults,
you'll have to
quite often find patients are obstructing even with the nasal airway because the length is not enough. Several occasions I have actually mentioned this to Romson rep in person. They haven't made any attempt to actually to rectify the problem.
You'll have to add 0.5 mm to the regular size.
No, Ramson is actually more stiffer than the endotracheal tube.
Not the nasal airway. Nasal airway is not stiff. Nasal airway is actually soft. In fact, Portex is very expensive. Romson is cheaper, but the problem is it's not long enough. I'm talking for adults. For children, it might be a different kettle of fish.
The endotracheal tube, I put it in hot water, then it becomes softer. Then I put it in the patient. When I use it in the patient, because of the patient's warmth, it stays softer only. So
yes.
I routinely dip it in the hot water before I insert it as a airway.
For nasal intubation, we regularly actually dip it in hot water and use it because it may be a supple for nasal intubation.
Very often we
Yes, we used to do that in UK because the fluid warmers for blood warming used to have hot water. So before inserting a nasal tube, we always put an endotracheal tube along with the cover because to keep it sterile. Along with the cover, it is actually put in the fluid warmer for the.
Sure.
Yeah, before inserting. The other thing I wanted to actually ask you about was this comment you made about extubating patients on the right lateral. I think the conventional teaching is left lateral, isn't it? What is your justification for putting the patient left lateral?
Absolutely.
I mean, right lateral.
Absolutely. I put that thing deliberately in my, since most of my anesthesia machines are on the right side. But what is the conventional treating is on the left side because tongue falls on the left side. If you want to intubate,
absolutely,
intubate in an emergency, the tongue falls on the left side, and therefore you're able to get the tongue away from on your visual field. But that good that you noticed that because this lecture was meant for my residents, my trainees. Most of my anesthesia machines are on the right side.
Okay. Yes.
So it's much more easier for.
Yeah. Tonsillar recovery position is left lateral head down. And as you said, if you need to re-intubate, you can actually put the laryngoscope with the patient on the lateral, left lateral, rather than the right lateral, where you'll be struggling to push the tongue right up.
Subbiah sir, but actually, right lateral actually reduces the reflex from the stomach. In fact, rather than left lateral. If you put the patient,
you're not worried about anything coming from the stomach. In this elective patient, in elective patients, you're not worried about things coming from the stomach.
Patients, okay.
Correct. But what he mentioned is correct. ENT cases, we always have on the right side. Okay, the machines are on the right side. So I will prefer the patient to be on the right side. Okay. So that's what he said. It's a practical thing.
It actually it depends upon the individual anesthetist, basically.
Correct.
Anyway, and the last thing I wanted to ask you about, which Dr. Rajani would be very interested in knowing, is about your deep extubation technique. Can you describe how you do it, please?
Okay, so how deep extubation? So leave the if the patient is make sure the patient is breathing spontaneously. Leave the concentration of sevoflurane or halothane or isoflurane, whatever you have, in the same level as it is. Make sure you hit about 5 ml per kg body weight of tidal volume, and you have a very steady state plane of anesthesia. If you want to put them on the right lateral or left lateral, whichever position you choose, that's okay. You can use that. What I've tried to do nowadays is use at least 2 milligrams per kg of propofol as IV before extubation. So what happens is most of the time the patient actually stop breathing or become hypopneic, and as soon as they start breathing, take the tube out. The propofol acts as it actually deepens the plane of anesthesia. It also obstructs the airway reflexes, and also reduces the post-op laryngospasm in this type of patient. So do this technique, and I think I have a very good success rate with 2 milligrams per kg body weight of propofol before extubation. The patient goes apneic, and then as soon as the patient starts breathing again, take the tube out.
There's a lot of difference between taking the child deeper with propofol and inhalational agent, isn't it?
Yes, absolutely.
Propofol is such a short acting because you know that the child will have the reflexes of tended or whatever for shorter time. Otherwise, your concern will be if you are extubating deep lanes, what if the child has problem in the post-operative ward after the child is shifted to the ward, isn't it? So probably propofol is a better choice.
Yeah, I don't feel inhalation will be a good choice. What is it? With propofol alone is a good one, but having inhalation at the time of extubation, as Madam said, for example, a freelancer like me, you cannot do that.
Yeah, absolutely. Depends upon what type of inhalation agent you use. If you use isoflurane, I wouldn't recommend that.
Isoflurane all over. Only the corporates have SIBO or this whatever the luxury you have. Isoflurane.
The isoflurane gives you high incidence of laryngospasm after extubation. So if you have isoflurane, please don't use it and use the propofol technique.
Personally, stop it at least 15 minutes before the surgery.
Yeah.
10 to 15 minutes, because the closed circuit will have an effect of 5 to 10 minutes. So 15 minutes will be the time to switch it off.
Okay.
Great, thank you. That's pretty much what I do as well.
So I think.
Thank you. That was a good talk.
Thank you.
Yeah, thank you everyone. Dr. Raju, I personally thank you.
Thank you, Srinivasan. Thank you, guys.
Madam, thank you, madam.
Right, listening to you.
Thank you,
Thank you.
Dr. Rajani Sundar. So Srinivasan will have my email if you want to get in touch with me.
Yeah, sure.
Thank you, sir.
I'll share it. So I thank everyone and all for attending the meeting, and personally thank Dr. Sudarshan and Dr. Kribakaran, the state office bearers. Actually, in fact, I was expecting a little more today, but somehow I don't know. But I'm personally very happy because what to say, I had a lot of doubts regarding this pediatric ENT, which I do every week. So, thank you, sir. Thank you, Dr. Raju.
Yeah. So if you want more lectures, I have a series of lectures. If you want, I can.
We'll have in next year, 21, we'll have one of
Yeah.
your lecture. Yeah. Thank you, everyone.
Thank you.
Make use of your presence during the state meeting also. The coming months, coming weeks, we will have.
13 ல இருந்து 16 மணிக்கு தான் போனா
You are
இத்தனை
free.
விக்கெட் இருக்குது அடிச்சு பிரிக்கலாம்.
Right. Okay. Shilpa, we can close the meeting.
Yeah. Thank you.
Thank you.